All right, guys. We only have like 80 slides to go through. So obviously you're going to have the rest of the time to either take your final or the end of the week. Your final's not due till Friday. So I'm leaving it open up until then. It is open book, open resource, completed. It's 100 questions, nothing too intense. I sent you guys the guide on what all it entails, what all it covers. I'm going to go through the PowerPoint, then afterwards, I'm going to give you guys a break. And then I'm going to go over Platinum a little bit because there's some questions about documentation. So I'll just clear up any of those questions at the time. And then when that's all said and done, you guys are free to go for the night. So we'll get into this. Are there any questions before we get going here? All right. All right. Anybody that's on here, are you guys good on seeing my screen?
Yes.
Okay.
Yes.
Yep. Just making sure. Pathophys, there's not a lot in regards to this chapter, just because again, pathophys is really just the study of disease processes. Well, next semester we cover each system is its own lecture. So, endocrine, neurologic, and in those is the disease processes themselves and the disease that we are looking for and the associated signs and symptoms with those diseases. So I wouldn't spend as much time trying to memorize, different types of cells and what those cells functions do, because in the grand scheme of things, even for testing and national registry content, they don't really hit home those things. What they look at is the disease processes themselves and our assessment of them, and what things are we looking for to determine if those disease processes are present or things that a patient might be complaining of. So anytime you hear the word pathophys, I want you to think of it's really just the study of diseases of a cell. Well, we know that multiple cells make up a tissue, multiple tissues make up an organ, multiple organs make up us, an organism. So the study of pathophysiology is really what disease processes do us as humans, what are we prone to? What things can be risks to us to develop diseases? What things make diseases more prevalent? What things help grow, help fester diseases? A lot of it could be, family disorders. A lot of it could be genetic, could be based off your lifestyle, could be based off the environment. So there's more than just looking at cells or this type of cell attacks or anything like that. It's really a whole lot more than that. When we talk about a little bit about cells, there's some key words here. And the way I remember them is kind of easy. When we talk about like atrophy, so if a cell is going to atrophy and die or decrease in size, that could be due to normal cell death. That could be due to an injury. That could be due to some sort of attack by a foreign invader. But anytime a cell is going to decrease and really degranulate, which is releasing its contents, that's what's called atrophy, decreasing in size. Now, on the opposite end of the spectrum, we have hypertrophy. Think of somebody that goes to the gym all the time or goes running all the time or whatever it might be, and then they just suddenly stop. They're going to lose muscle mass. They're going to atrophy, as opposed to if they go to the gym consistently, they're going to grow muscle. So those cells are becoming hypertrophic. They're growing in size. They're increasing the number as well. If we need to increase cell numbers due to injury, due to infection, due to some disease process, that's what's called hyperplasia. Remember, hyper means above, hypo means below, or high or low. So anytime you see the word hyper, it's going to mean more than or a higher number. Dysplasia is when cells just kind of take a shape or a certain size that isn't normal. When we at the end of the slideshow, there's a disease process, muscular dystrophy. It's really when the cells of the muscle aren't normally shaped. They're not retaining a normal function. So the people with muscular dystrophy can have muscles that aren't either A, working correctly, or B, you can actually see like extremities that are kind of bent in different directions. And it's not anything they've done wrong. It's just genetics a lot of times that they end up with these cells that are dystrophied. And then metaplasia, which is when a cell is replaced by another. This, again, could be to common cell life. So as cells go on, just like us, things are going to die, and another cell is going to replace it. So that's what metaplasia is. If I was going to tell you to remember a whole lot from this PowerPoint, I'd be lying to you. I would probably remember these: atrophy, hypertrophy, hyperplasia, dysplasia, and metaplasia. in regards to things to maybe jot down. Now, I take notes differently. If I'm sitting in on a lecture or anything like that, I don't write verbatim word for word what I saw. What I do is I make a note. So like atrophy, and then I'll put a star next to it. What that means is when I go back and look at the notes, it means, hey, look that up because you don't know what it means. So that's just how I take notes. It might help for some of you in note taking. We've already talked about this, and we know that the body is mostly comprised of water. You know, literally water weight each day, you can see a shift of 15 to 20 pounds just in water weight alone. Now, there's going to be some reasons why somebody would carry more water or carry less water than others. It could be a sodium imbalance. It could be a disease process such as congestive heart failure. But the body is always trying to maintain homeostasis. If it decides that we have too much fluid, it's going to kick our renal system in. It's going to make our kidneys go into hyperdrive. It's trying to get rid of that fluid. If it decides we don't have enough, it might retain sodium because, you know, water is going to follow salt. So if we retain sodium, then we should be retaining water. Anything that our body does, we're constantly trying to stay in that ready state, that homeostatic state. So the reasons why some people might retain more fluid or maybe not enough could base off their size. Smaller people aren't going to retain as much fluid as a larger person. Be based off their age. Anything with ages, when I refer to the extremes of age, we're talking about our infants or our elderly populations. Those are the populations that are most at risk for disease processes. So really old and really young generally aren't going to retain a lot of fluid. They don't have the disease processes. They don't have the conditions that warrant their body retaining fluid. Their body's still very much trying to figure out what it wants to do at the time, especially in our infant populations, as opposed to our elderly populations. Their body is just kind of, it's slowed down a whole lot. And again, maybe some underlying medical conditions, such as congestive heart failure. Depending on what type of heart failure somebody has, fluid is going to back up in either the lungs or it's going to back up in their extremities. And we get what's called edema, which is just an overload of fluid in a certain area. And when you see the word interstitial, I want you to think that's the space right around the blood vessels. If I was to go from my vein to the tissue right outside the vein, that's our interstitial space. Another term for it could be like extravascular, outside the vasculature. But reasons people are going to retain this fluid, or the reason they even get edema in the first place, is over time, if they have increased pressure with inside those vessels, it's going to leak out. You know, our vessels can only withstand so much pressure, and over time they become weakened, and that fluid can slowly leak out. As I stretch something, think of a balloon, as I stretch it, the walls become thinner. So if I stretch those blood vessels over time, they're going to allow fluid in and out of them. It could be also due to an obstruction, not allowing fluid to return back to the heart. This could be something as simple as a DVT or a deep vein thrombosis. It could be something so severe as a PE, or again, congestive heart failure. They just don't have the pumping ability, so that fluid has to back up somewhere. And in this case, it either backs up in the lungs or it backs up in the person's extremities. Now, the patients that scare me the most with CHF aren't the ones that I also take and think I hear crackles. It's the ones that when I walk in and I can just hear them almost gurgling the second I walk in the front door. Those are the ones that I tend to aggressively treat a little bit more, I would say. So anytime you hear any sort of crackling in the lungs, generally it's caused by left-sided heart failure that's backing up. Now, as opposed to if somebody has edema showing up in their legs or their extremities, that's usually caused by right-sided heart failure. You know, blood returns to the heart on the right side. So if the right side is failing, it's not able to pull that excess fluid out of the body. So it has to back up somewhere. Gravity says it's mostly going to back up in the legs. That's where we see the patients with, you know, pitting edema that we can kind of push our fingerprint into. Anytime we have any sort of edema, I don't care if it's in the lungs, I don't care if it's extremities or what, we probably should be looking at cardiac monitoring with those patients. And again, when we get into cardiology next semester, I'll talk about more what patients warrant cardiac monitoring versus not. But in terms of somebody that has fluid in their lungs, you know, a big treatment for us, if they don't have any contraindications, is putting patients on CPAP. You know, that's going to open up their lungs. It allows their alveoli in the bottom of their lungs to open and close. We get that exchange of carbon dioxide and oxygen. But that fluid still has to go somewhere. Generally, a lot of protocols will say, hey, you know, administer nitroglycerin in addition to CPAP. So they might issue nitro, right before they put the patient on CPAP, what they're doing is they're, again, expanding those blood vessels. They're dilating them. Nitroglycerin is a dilator. They're expanding those blood vessels in hopes that the wall becomes thin and that fluid can go right back into the vessels and we can somehow get it back into circulation and get rid of it. Over time, that's the emergency treatment, but over time, they might keep the patient on CPAP. They're probably going to end up on some sort of diuretic, such as Lasix, just to be able to filter a little bit more than their body usually does, because they really don't need to be hanging on that much fluid. Some of the electrolyte imbalances you'll commonly see, there was a whole bunch of electrolytes listed on this PowerPoint. The ones that are very pertinent to us as paramedics are sodium and potassium. The reason it's very pertinent to us is because sodium and potassium make up a pump, and this pump is what is responsible for creating action, especially within our heart. In our heart, we have literally a sodium potassium pump. Generally, potassium is on the inside of the cell, sodium is on the outside. And again, the cells normally at rest are negative. So what happens when we want to initiate an action, create a heartbeat, whatever it might be, is there's these little gates that open up in these cells in the sodium potassium pump. They let the potassium out of the cell, they pull sodium in. That now makes the cell positively charged. We went from a negative to a positive, and that creates action. That's what we're looking at on a 4-lead. That's what we're looking at it on 12-lead, is those little blips is the sodium potassium pump at work. The way I always remembered it when it comes to sodium potassium is K in, not out. So K is you think periodic table of elements, K is potassium, Na, Na is sodium. So potassium on the inside, sodium on the outside, and they just constantly exchange. Now, when we go back to resting, potassium goes back into the cell, sodium goes back to the outside. That's repolarization, resetting. You don't necessarily have to know your specific lab values in regards to electrolytes. I honestly didn't until I went through and went through my CCP class. It just wasn't pertinent for me as a paramedic to know all these sodium, potassium levels and magnesium levels and calcium. Now, is it pertinent? Sure. If you do maybe some interfacility transfers or you do a lot of transfer for your hospital, sure. And that's something you can absolutely learn. I carry a cheat sheet with me on the back of my ID card wherever I'm working that tells me normal lab values. So that way I can know, okay, if somebody's holding on to too much sodium, let's say their level of sodium is 160, I can expect them to be holding on to fluid as well. Now, with electrolyte imbalances also, we can see weird things happen. We can see patients even go into cardiac arrest based off of their sodium potassium being off. So electrolytes do play a role in normal bodily functions. Cells not only become injured through normal processes, I wouldn't even say injured, we'll just say die through normal disease processes, but they can become injured. And this is more of a traumatic injury than anything. So the ones that we're going to most commonly see is hypoxia, obviously due to reduced amount of oxygen, ischemia, which is reduced blood supply, maybe a chemical injury such as, carbon monoxide, even lead poisoning. Infectious diseases are going to take a toll on cells. Any sort of immune system response or immune system injury, maybe somebody has a chronic immune system problem. Physical trauma itself, and then damage that's caused by our inflammatory response. So we're going to get into each one of these sections here shortly. They each have their own slides, so I'll explain a little bit more when we get to those. Now, hypoxia is probably going to be the one we're most likely to deal with. This could be patients that have exerted themselves for too long and they become hypoxic. This could be patients having chest pain that are ischemic, and what that's doing is it's reducing the amount of oxygen being carried in the blood. But think of a brain, on average, and this is one of the 10 test questions, 4 minutes is pretty average before we can potentially start to see cell death of the brain itself. Well, think about you guys at 2 a.m. You're working at your service, cardiac arrest call goes out. Within 4 minutes, can you get out of bed and to the person's house doing CPR? Maybe if they live right next door, but even then, that's gonna be a long shot in 4 minutes. Cells tend to die pretty quickly. Now, in a normal body, these cells are normally replaced through metaplasia. They just kind of replace each other. As something dies, something else comes up. Sometimes the body cannot repair its cells like it should. If it cannot, then that tissue becomes dead. And that dead tissue is what's called necrotic, or we have necrosis, which is cellular death leading to tissue death of a certain area. Think of like gangrene. That's a good example of necrosis. Something to note, especially in this slideshow, and it was never explained to me a whole lot in depth, is free radicals. And what free radicals are is they are a dangerous mediator that when our body becomes hypoxic, these free radicals kind of just travel around our body. And the bad part about it is that free radicals just randomly attack cells within our body. So let's think of like a COPD patient. If we have a patient that normally sits 84, 85%, our goal is not to get them up to 97. Our goal is to keep them at the 84 or 85, especially if that's what their body's used to. The second we introduce a whole lot more oxygen, their body is going to freak out. Their body doesn't know what to do. These free radicals could start attacking the body itself. It's going to be very much the same with chest pain patients. As an EMT, we're taught anybody with chest pain, I don't care what's going on, you throw them on 10 liters non-rebreather and get their oxygen saturation up. That's not so much the case anymore as a paramedic. We're shooting for an oxygen sat of 94%. Right around 94%, I'm okay with. I'm not trying to get that patient at 100% because, again, there's a part of their body that is hypoxic due to ischemia from an MI. Those free radicals are released. If I introduce a whole bunch of oxygen, their body's going to freak out and start attacking itself. That's just the reason why we don't do it, is we're trying to do what's best for the patient at that point. I mentioned earlier, like common chemical injuries we can see for cell death. Lead poisoning is a pretty big one. It's not something we commonly see. Really, to be honest, I was researching why they would have even put lead poisoning in here. For some reason, it's a leading cause of cell death in the U.S. I don't understand that. One of the leading causes, I shouldn't say. Cyanide, pesticides, that's actually a lot more prevalent than you think, especially here in the Midwest. What was it, a couple of years ago up north of Des Moines, we had a field full of workers that were sprayed by a crop duster. Well, those patients all ended up having pesticide overdose or a cyanide overdose. So technically a mass casualty incident, common poison, yeah, for that area it absolutely was. And that one thing that's always hit home for us, especially when I was going through paramedic school, was you have a patient who's not acting right, that's in like a garden center or in a store where they have a lot of pesticides or chemicals or anything like that. Get them out of that environment, get them into fresh air, and see if things start to turn around for them. Because who knows if something's been spilled in that environment? Who knows if they've been sprayed by a crop duster? There's a lot of things, but here in the Midwest, cyanide and pesticides actually are a concern. The other big one, especially in cold states, is carbon monoxide. We get people that use propane heaters. We got people that maybe their HVAC system isn't working like it should. People that maybe leave their car running in the garage without cracking their garage door. Here, we're going to see it more often than not, versus a state where they have a little bit better climate. So we're more likely to see it in this instance. Think, house fires. House fires lead to carbon monoxide poisoning, especially not just for our patients, but for us, especially as first responders, if we're not careful. Looking at their pulse ox is going to tell us nothing. All it's going to tell me is how much hemoglobin in their blood is bound by something. Put those patients on end tidal. There is no fine line of, should I put this patient on oxygen or should I not put this patient on oxygen? I had a student ask me that, well, if I have that COPD patient or I have that patient with carbon monoxide, but everything's fine and they're still complaining of having some trouble breathing, can I put them on oxygen? Absolutely, you can. That's treating based off of what your patient's complaining of. A lot of times we aren't treating an injury or a disease process, we're treating a complaint. And if by you putting oxygen on somebody, they're able to calm down and they feel a lot better, by all means do it. I'm not saying don't, I'm just saying be careful for some side effects that could occur from it. Are we going to potentially see it? Sure. But it's more or less going to happen in the hospital if we overdose somebody on oxygen. I hate saying overdose of oxygen, but that's really what it is. Infectious diseases, infectious injuries, more or less, something we literally have lived for a couple of years now. Anytime we're talking about viruses or bacteria, in a way that the CDC and, Center for Disease Control and other infectious disease experts measure how deadly or how sick somebody can get from a disease is they look at what's called virulence. And that's what ability does this disease carry? And what can this disease really do to a population? Pathogenicity is, can this disease reproduce? How does it reproduce? Can that change? Absolutely can. Can it reproduce just in humans? Can it reproduce just in animals? Absolutely. And they can transform to where we can now pass those maybe human to person or human to animal or animal to human. So that's stuff that's always being measured. Again, I wouldn't pay a whole lot of attention to that. If you're going to remember something, virulence, the disease causing ability of a organism, of a virus, of a bacteria. Does this bacteria have disease causing capabilities? So to determine if something is a bacteria, and especially if it's a bacteria that can cause harm or has that disease causing capability, they do what's called gram staining. And what this means is it's actually stained with a red dye. So any bacteria that resists that dye is called gram positive. And that tends to be the one we're a little bit more worried about. The ones that do not resist the dye and become the color of that dye are what's called gram negative. They're not as potent as gram positive bacteria. Now, our biggest concern with bacteria is what they can do. And it's not necessarily that they're tearing apart natural cells we have inside of our body. It's that they're producing something called exotoxins and endotoxins. Exo meaning outside, endo meaning interior. So toxins come from inside the cell, endo come from outside of it. What they do is they either attach themselves onto the cell on the outside or enter the cell and literally rip it apart from the inside. That's how a bacteria functions. So how does our body fight that? When our body realizes that we have some sort of bacteria inside of us, it has a couple anatomic barriers and processes that it follows to make sure that we try to remain safe. So the first one is our body releases pyrogen. Pyrogen generally causes us to have a fever. A fever isn't us being sick. A fever is our body trying to compensate and trying to kill what's inside of it. It's literally trying to burn out the bacteria. What else happens is we get inflammation to a certain area. Somebody has a sore throat. It's generally due to inflammation of the uvula, right around your, where your upper airway meets your lower airway. Chills, because your body responds to sickness might be to create action. General weakness, because we're exhausting all this energy trying to fight whatever disease or fight whatever bacteria it is. If our body cannot fight it and we do not manage it, that's when we see patients potentially go into like septic shock. They become very septic, they can become very sick, and their body and organs start shutting down at that point. As opposed to a virus, which is going to be more of an intracellular process. It's more of a parasite. And what happens is a virus just replicates itself over and over and over and over again until it's taken over a certain area. So it doesn't necessarily just go in and start attacking cells. It goes in, kind of mingles with the cell, gets close to it, becomes its friend, then starts replicating using that cell's energy. Then once the body is overtaken by that virus, we have no cells to fight off. Again, our body's response, our body is always going to think that through dilation, we get more blood flow, which is correct. I can blow a lot more air through a toilet paper tube than I can a straw. So our body will try to dilate because, again, we want more blood supply to an injured area. It will increase our blood vessel permeability when we dilate. Remember, as we stretch, walls become thin. Our body also releases something that attracts what's called leukocytes. Leukocytes are a form of white blood cell. They are rushing to that site of the injury. So when something is injured, it sends out a message saying help, basically. White blood cells see that message, they rush to that area to try to help. And our body develops a fever through pyrogen to try and burn out whatever it is. That's when we get as you see at the bottom, heat, redness, tenderness, swelling, pain. It's all from our body's natural response to things. Now, can our body respond to traumatic injuries in the same way? Absolutely. I get hit in the arm with something, I get immediate bruising, it becomes inflamed, it becomes swollen. That's because of blood cells rushing to the site. That's because of the body's natural response, such as a local effect. Local would be isolated to a certain area versus a systemic effect would be like sepsis, where whatever it is all throughout my body. The common flu would technically be a systemic, as opposed to something that's just isolated to a certain area. Now, when cells normally die, everything dies at some point. That's what's called apoptosis. Now, our hope is that cell has reproduced prior to dying, or that cells are right behind it to take its place. But the cell just kind of almost like rips itself apart. And the nutrients that were inside the cell that could be used are then spread throughout the liquid, throughout the bloodstream, and our body uses them. This is called degranulation, when our body kind of takes these cells and literally flakes them apart. Apoptosis, normal cell death. Degranulation is when the cell tears itself apart. I talked about necrosis already, when tissues die, when tissues can no longer reproduce, when they can no longer repair themselves, when we get cell death. That's a common fear, especially when we have patients having chest pain or patients experiencing an MI, is what's happening in the heart is that one of the coronary arteries, one of the arteries along the heart, has a blockage through plaque, through a clot, whatever it might be. Well, that blockage is going to lead to hypoxia of that area. That area is then going to become ischemic and injured. Well, after a period of time, we're worried about that part of the heart dying due to the lack of oxygen, due to the lack of blood to that area. Perfusion, normal way that our body circulates nutrients. That's just normal blood pressure. Think of perfusion as things are circulating how they should, organs are getting perfused, our heart's getting perfused, things are moving like they should. Versus hypoperfusion, which is shock. Anytime you see the word hypoperfusion, I want you to think of shock. And what happens in shock is that our body starts to compensate. So it sees that our blood pressure is low, it kicks up our heart rate. It tries to compensate through that. It sees that my organs are starting to have a problem. It shunts blood to my organs and away from my extremities. That's why somebody can feel like they are cold. That's why they feel like their arms and legs are getting cold. That's why they might start to shiver. That's our body saying there's a problem. I'm going to start to compensate. The problem is our body can only compensate for so long. And these are patients that you're going to see with maybe a normal blood pressure, but yet their heart rate's increased. Now, what happens is after a period of time, their body's going to go into decompensated shock. That's when we start to see a heart rate that's lower and the blood pressure is also tanking at the same time. Our patients will compensate for so long before they decompensate. Now, kids don't have the ability to compensate as long as adults do. Kids kind of go up and then they just go right back down. So our body will have some sort of compensatory mechanisms if we are potentially going into shock. Now, how our body tries to maintain blood pressure. We have something called the RAAS system, which is the renin-angiotensin-aldosterone system. So our body will release renin. In response to renin being released, another organ will release angiotensin. Okay, the blood system, this body sees angiotensin floating around, it releases what's called aldosterone. What this does is that it tells your body, hey, stop filtering, stop getting rid of fluid. I want my blood vessels to constrict, and I want my heart rate to increase. It's telling our body, those are the chemical messengers telling our body to compensate during shock. Our body also releases ADH, antidiuretic hormone, to assist in maintaining fluid, to assist in keeping fluid inside, assisted with keeping the fluid inside of us. We don't want the body to get rid of anything. We don't want the kidneys to be working overtime at this point. We're trying to keep as much fluid as we can inside of us until the body can either maintain that homeostatic level, until it can fix whatever's going on, or until us as paramedics have to fix the patient. Our heart will generally be the first thing to fail when we start to decomp. That's when we start to see the heart rate go down. Think of a car engine. Car engine can only go for so long, especially if you're sitting there with your foot on the gas the whole time. You're sitting there and you just, bury your foot on the gas pedal of a car. It can only do that for so long before it finally starts to slow down or it starts to implode. Very much the same with us as humans, is our heart can only take so much before the pump starts to die. We can see leaking from blood vessels due to compensation over time. We'll see tissues that are starting to become necrotic or starting to become injured because, again, our heart rate's increasing, but just because my rate increased doesn't mean the volume increased. My heart can only squeeze so much in a short period of time. Types of shock that we're going to commonly see in regards to central circulation, in regards to peripheral circulation. Our body is going to use as much fuel as it can when it comes to shock. It's trying to literally keep itself alive. At the point that it starts to run out of oxygen, we go back to anaerobic metabolism. It starts acting without oxygen. The problem is then it's relying so much on glucose. Well, once that glucose is gone, we have nothing to convert to energy. We have no fuel for the body at that point. So that's why it's important, especially if somebody's fighting off infection, somebody's fighting a sickness, whatever, nutrients is huge because that's fuel for the body to be able to fight off whatever it is. I mentioned circular and peripheral circulation when it comes to shock. So when I talk about shock centrally, that's the heart failing. That's something with the heart. That could be cardiogenic shock. Maybe the heart just can't push enough blood like it was, or something is blocking the heart from doing its job. Central shock is right in your chest. If I was to say, bulletproof vest, what do those protect? They can protect just your vital organs. Think of that as like your central core. That's what your central shock is affecting, as opposed to peripheral shock. That could be something like severe bleeding, severe blood loss, something that outside of the core that is causing us to become hypovolemic. This could be sepsis. This could be, again, a severe laceration, traumatic injury. It could be something such as neurogenic shock, where our blood vessels are dilated. We have distributive shock. Any type of shock, I don't care what it is. There's one of three problems. You have a pump that's failed, you have not enough fluid, or you have a pipe system that has failed. One of those three, a bad pump, not enough fluid, or the pipe system has failed. Any form of shock you can think of incorporates one or if not all of those. So common types, anaphylactic shock. What's happening in anaphylactic shock? Well, something the patient is very hypersensitive to. It's causing them to, their heart rate to decrease. It's causing their blood vessels to dilate. Through dilation, we're seeing drop in blood pressure. Septic shock, same thing. Your body's trying to keep all of its perfusion into the core. It's trying to keep as much fluid as it can into your vital organs. So it constricts centrally, but it dilates peripherally because it doesn't care about your arms and legs. It cares about what's inside of you. Neurogenic shock, severe spinal cord trauma, severe spinal cord injury, blood vessels dilate. As something becomes bigger, if we don't replace it with fluid, if we don't replace that empty space with fluid, pressure is going to drop. If I blow through a straw versus blowing through a toilet paper tube, there's going to be a lot more pressure coming out of that straw versus that toilet paper tube. There might be more volume out of the toilet paper tube, but there's not enough pressure. And that's what happens when we talk about dilation versus constriction. So how do we manage it? A lot of what we're managing with shock, and even how does the patient manage it? A lot of what we're managing is we're managing signs and symptoms. We know that in shock, the heart rate's going to increase because it's trying to move a lot more fluid. So we might be giving these patients fluid. Now, if we're going to fluid challenge somebody or give somebody a massive amount of fluid, make sure we're listening to lung sounds, because that's usually one of the first places that fluid will start to back up. Things we should be looking for if we're worried about shock: modeling. Sure, that's telling us that the tissue isn't being perfused. Change in color, maybe the patient's becoming pale. Again, our red hue to us, especially when think of somebody having an allergic reaction, they become red in color, kind of. That's because their blood vessels are dilated. You're seeing the red color of their blood vessels, as opposed to when somebody's pale, that's because their blood vessels are constricted. Cyanosis, we start to see fingertips, we start to see lips starting to become blue. Even delayed cap refill, that's huge in kids. Cap refill, not so much in adults, but in kids, that is a huge indicator of perfusion, is looking at cap refill. Anything greater than 2 seconds could indicate a level of dehydration in kids. All right, I'm gonna give you guys a 7-minute break before we keep moving on. We're just about halfway through this. So the next portion we're gonna cover is when organs start to shut down, multiple organ dysfunction syndrome, but take 7 minutes, 6:42, and we'll keep going through this slideshow. All right, I promise the next sets of slides aren't as bad as cells. I mentioned how coming up is talking about multiple organ dysfunction. So as we get some sort of sickness, some sort of illness, again, a bunch of cells make up a tissue, a bunch of tissues make up an organ, a bunch of organs make up an organ system. Well, when we have one to two or more, I'd say, organs that start to fail or that are affected, that's when we go into what's called organ failure, or MODS, multiple organ dysfunction syndrome. And this is usually really sick people. And we saw this a lot with COVID patients, is that more than one body system was affected. Patient being on a ventilator, their thyroid was causing their vital signs to be elevated, their heart rate was really up, their blood pressure was up. Everything was just going wrong with these patients. They were going into multiple organ dysfunction. Now, there's a couple different types. Primary is there's direct result of an injury. Now, secondary would be more of like a chronic long-term illness, like organ failure due to cancer, organ failure due to some disease process. It wasn't that organ failure that just decided to give up and quit, or organ that decided to quit. It was a disease process that caused the organ to fail. That's secondary, as opposed to the organ just kind of shelling out on its own, which would be primary. Now, our body can very much fight organs within inside of us as well. Like it can almost turn on itself, especially if, think of organ transplant. Somebody that gets a transplant, their body kind of rejects it. What happens is their body sees it as a foreign object or a foreign bacteria or foreign substance or whatever it is, and starts to attack it. Now, any sort of inflammation, any sort of systemic response that our body initiates can have a toll on a lot of our organs. Again, I had a problem with my liver probably 3 years ago. I was super sick. It took a toll on my liver. I still have elevated liver enzymes because of it. And what happened was I was starting to jaundice over a period of time, over a period of a week, actually, just because my liver wasn't able to keep up at that point. So a concern at the time was, are there any other organs that are affected by what was going on with me? So they had to run a whole bunch of series of tests to make sure that it was just the one organ. If it was two, then there would have been a concern of me going into MODS or having more than one organ fail. And at that point, if I have an organ that maybe controls filtering and an organ that maybe controls bile, let's say, okay, those are two different processes, two separate organs, but that's now two systems that are shutting down within inside my body. That's why one of our biggest fears is somebody in MODS is their body just can't compensate. And it comes to a point where the body just shuts down over a period of time. They exhaust all the energy that they have and their body just shuts down. In response to any sort of infection, any sort of sickness, any sort of illness, even allergies, we have a couple different lines of defense. First one being our skin. That is our first anatomic barrier that we have. Any substance cannot just enter our body. It has to pierce through our skin. It has to be inhaled. It has to be absorbed. It has to be ingested. So our skin is very much the first line of defense we have. Think of pepper. If you're cooking something, you smell a whole bunch of pepper, or you get pepper in your nose, what does your body do? Naturally, it sneezes. That's a body's defense mechanism to get rid of something that is in its nose it doesn't want, is it's going to sneeze. Your sinuses will become clogged up. Your sinus canals will almost constrict, try to prevent whatever it is from entering your body. We have the inflammatory response, which is whatever area there's an injury, whatever area there's an infection, we become inflamed. We get all these blood cells that are going to rush to the area. Again, think of a sore throat. The area around your throat becomes inflamed. It hurts. It's painful. It's swollen. And then we have immune responses. So think of common allergies. Pollen. I do not agree with pollen. I had horrible seasonal allergies. What happens is my sinuses constrict. I get really congested. It produces a lot of mucus because it's trying to prevent anything from entering the body. That's the body's way of saying, okay, we know there's an issue with this. We've sensed it. We're going to put in place these trigger points, these processes to make sure that it doesn't enter. If for some reason it is ingested, another line of defense that I didn't bring up is the stomach acid. is our stomach can chew through a whole lot of stuff just based off of the bile and the acid that we have inside of our stomach. So there very much is a line of defense as well before it gets to our digestive tract. So what happens during an immune response? Well, the first time we're exposed to something, our body doesn't react. It has to recognize what it is first. Our body kind of eyes it up, doesn't know what to do with it, doesn't even know how to attack it. So the first exposure we get, generally there's no response. The second time it's exposed to the same thing, the body has now learned what it is, how to fight it, and what to do at that point. So we get exposure, and then the second time around, we attack it because our body's learned enough about it. That's why we undergo allergy testing. That's why we go you determine if we're sensitive to something versus allergic. Sensitive, we might get a mild rash. We might get a headache, something like that. My wife, she's sensitive to eggs. She's not allergic to them. She just has sensitivity to them. She does not get a full immunologic response. Her body she gets a headache when she has them. So there's different types of responses that our body can have depending on how sensitive we are to something. If we're severely sensitive to something, then that's when we get severe anaphylactic reactions because our body's in full-on attack mode at that point. Anytime, this is just a good rule of thumb for you guys, anytime you see any sort of cell or blood cell that starts with an L, it's a white blood cell. Leukocyte, lymphocyte, those are white blood cells. Think of leukemia. That is a type of cancer dealing with excess amount of white blood cells. Anytime you see an L, it's a blood cell, think white blood cell. White blood cells do what? They fight off infection, they fight injuries. They really are attacker cells. They're meant to keep us healthy. Now, can they attack us? Sure. That's when patients with leukemia, is their body essentially attacks itself due to an excess amount of white blood cells. So once a bacteria, we'll call it even an allergen, enters the body, again, we have to identify what it is first. After it's been identified, the body goes into attack mode. After it goes into attack mode, we have what's called B cells and T cells. Now, B cells are more memory cells. They're the ones that say, hey, I've seen this guy before. I know how to attack him. T cells are very much the attacker cells of the bunch. They're the ones that B cells are saying, hey, that's him. Go get him. The T cell is the one that really is going to do the most damage when it comes to going through and kicking out allergens that should not be inside of our body or destroying them entirely. Different types of cells that we'll see during immune system response. If you want to go through all those, you can, by all means. It's in your book. It's in this PowerPoint. You're more welcome to look each single one up. We're not going to talk about every single one in this PowerPoint. The big ones that you need to probably ingrain in your memory, B cells and T cells involved in an immune response. Now, how do we know if something is bad versus good? Well, we have natural immunity to something. Okay, like a good example of a natural immunity is I can walk through a whole patch of poison ivy and it doesn't affect me. Doesn't do anything to it. That's not because I have an acquired immunity. That's just natural. It's through genetics. Somehow I'm just not allergic to poison ivy. It does nothing to me. An acquired immunity would be like a vaccine. Let's take the flu, for example. When you get a flu vaccine, it's not preventing you from entirely getting it. It's making it so your body recognizes it. So that way, when it sees it again, it knows how to attack it. Because again, first sight is identifying, second sight is attacking. So any vaccine that we get isn't to prevent us from getting the illness, it's so our body recognizes the illness. Natural immunity is things we naturally have inside of our body versus acquired are things that either we had to develop over time or examples such as a vaccine. Now, there's allergens, there's antigens. Antigens and allergens. Allergens are going to initiate an allergy response, as to where an antigen is going to be more of a infectious disease response, more of an infection response, if you will. Allergen is going to kick up our immune system. It's going to get our allergies kind of going. It's going to get those lines of defense. as to where a certain type of antigen is going to get a bacterial response. That's when we're going to see a whole bunch of white blood cells rush to an area. That's where we're going to see our body produce a fever. That's when we're going to see blood vessels start to change shape, just because it doesn't know what's going on. It's trying to fight off an unknown at that point. Lymphocytes, obviously white blood cell starts with L. It is a blood cell. It is a white blood cell. Now, it is the main blood cell that is going to fight viruses, parasites, bacteria, common illnesses. You know, we have viral infections, we have bacterial infections. Lymphocytes are the cell that are going to fight that. Not all white blood cells do the same thing. There's certain groups of white blood cells, like that was in that chart. Each one of those cells is only going to attack a certain type of allergen or certain type of antigen. They don't all just attack everything. They have to know what they're attacking. They have a specific enemy, in easier terms to try to remember it. Now, inflammatory, due to some sort of irritation, due to some sort of sickness, whatever it might be, we can have acute inflammation. Think, again, strep throat. You know, with strep throat, it's very much an acute injury. It's not going to last forever. It's our body is responding to it because there's some sort of bacteria, some sort of virus maybe that's entered and is attacking that region. So the body inflames that area and sends white blood cells to that area, starts to change blood vessels. What happens is we get the white blood cells, we get platelets, just in case we need some red blood cells to carry nutrients, right? We have mast cells, which are attacker cells. And then we have our B cells, our B white blood cells, memory cells. Now, can there be chronic inflammation? Yeah, there absolutely can. Think of people that have like arthritis. That's a chronic condition. Think of carpal tunnel, chronic condition. That's a chronic example of inflammation. The ones that we are a little bit more concerned about, the body learns how to deal with chronic. The ones that we get nervous about are acute, because the body has to recognize it and then fight it off at that point. There's that word degranulate again. That's when these cells, again, start to tear themselves apart and release what they have inside them. Some of the things that can be released, let's think allergies for a second. If a cell degranulates because it sees an allergen, it releases histamine. Histamine is what causes hives. It's what causes blotchiness, itchiness. That's why we get Benadryl. It's an antihistamine. In response to that allergen, this cell will degranulate and release histamine. Everything inside of our body is just very much a messenger and a receiver. Every cell is a sender or a receiver for something much more complex, such as our brain. That's all we're doing. Stimulate mucus secretion. Okay, again, in an allergy response. Why do we stimulate mucus secretion? A, because we're trying to prevent something from entering the body, hence why we get really stuffy during allergy season. Or B, we're trying to push it down to our stomach acid because it's past our first line barriers. Now we're trying to get it down to our stomach acid. If you look at the second to last line, synthesized leukotrienes, and I'm not even trying to pronounce that word. Well, leukotriene begins with an L. Guessing it's a white blood cell, guaranteed. Now, the other word, I had to look this one up yesterday because I was like, what is that? Well, I knew that it had gland in it. What do glands do? They secrete hormones generally. So that gland is responsible for secreting the hormone that produces mucus. It's kind of funny how many small little parts, how many working parts we have inside of our body that just do one simple thing. Literally, that body, its only job is to secrete mucus, to create mucus. Another thing that happens, our body increases its level of fibrin. Fibrin is the clotting factor that we naturally have inside of us. Fibrin, fiber. Now, do we always need fibrin? No, but it creates it in case we do need it, in case we need something to clot, you know, due to an injury, due to even an internal injury. Something's torn, something's repairing itself. We need a fibrin there to act as a clot. We technically have some, as EMS we don't, but in healthcare, we have some things that are fibrinolytics. things that are clot busters, such as TPA, if you've ever heard that before, like with stroke patients, we're trying to bust up a clot. Are there people that naturally don't have clotting factors? Yeah, absolutely there are. And there's certain populations that have blood disorders, such as anemia, such as, we'll get into them here in the next slide. But that's what fibrin does, is it promotes clotting. Do we always need it? No, but it's there in case we do. It's just kind of on reserve in case for some reason, whatever injury we've got, whatever infectious disease it is, creates an opening, we can send fibrin there to make a clot, to make a little web almost. So how does our body naturally start to heal itself? And the healing process starts immediately. Right after what white blood cells are going to do and start doing their thing, we start to repair injured tissue. Think of if you've ever gotten a splinter that you could not get out. I hate splinters. I absolutely hate them. If you can't get that splinter out, you don't dig in there or anything like that, your body naturally tries to bring that splinter to the surface. Your body naturally tries to push it out through regeneration of the cells around it. So it's trying to literally push it back out the same opening. That's just your body trying to remove what caused this injury. Hopefully, tissue is restored. It might not always look the same, hence scar tissue. And then cells in that area should be regenerated. In the instance that they can't, that's when we get dead tissue. That's when we get that level of necrosis. Some reasons why healing might not occur like it should. Well, we need energy to heal. So we need nutrients. We need blood supply. It could be a foreign body itself preventing the healing. So if that splinter just stayed there, obviously they can't heal that gap. It's going to heal around it. Poor nutritional habits, poor lifestyle, even as us as a person think bigger picture. This could be eating habits. This could be risks such as smoking. This could be just really unhealthy lifestyles, lack of exercise, too much stress. Those are reasons why our body might not be able to repair or deal with certain things. Is it just can't. We have too much stress on our body. We talked about chronic inflammatory responses, persistent infection, presence of an antigen. Hypersensitivity is obviously going to be an allergic reaction. It's always kind of freaked me out. Severe allergic reactions are called anaphylactic reactions, but yet we still use the word hypersensitivity to more of a broad term to say this is when patients have an increased sensitivity to something, such as an allergy, such as an immune disorder, such as some sort of bacteria. There's also different types of sensitivity that patients can really have. So type 1 is going to be an immediate reaction. This is when we have more of an acute response. This is when we do, honestly, antigen or allergy testing. This is an allergic reaction. Type 1 is very much an allergic reaction. If somebody has a type 1 response, generally our treatment is we follow the allergic reaction guidelines. We give them epi. What epi does is it constricts blood vessels, it raises their blood pressure. We're hoping that we can open up some lungs, we can get some breathing a little bit better. Now, can we give epi besides allergic reactions, besides difficulty breathing? Yeah, as paramedics, absolutely we can. We can give epi for allergic reaction, even if we think that the patient isn't having trouble breathing now, but they might. We're being proactive about it. Type 2, this is really going to be more of a delayed reaction. This usually happens within a few hours of an exposure to something. What happens is whatever it is that entered the body releases something called some sort of cytotoxin. And our body has what's called a cytotoxic response. So it takes a little bit for our body to realize what's happening or to realize that this is essentially a foreign invader. And then the body goes into attack mode. You know, an example brings up is a transfusion reaction. If we give the wrong type of blood to somebody, you will not see an immediate reaction from them because their body is not used to it. It still has to identify what it is. It takes a little bit of time for their body to start fighting it. But once it does, again, we start to see a negative reaction from it. Anytime, especially with transfusions, if we're giving somebody blood, as paramedics, we can maintain blood and we start to see a negative reaction, we should probably stop what we're doing. Stop the transfusion, stop whatever it is. But type 2 takes a little bit more time in regards to a sensitive response. Type 3 is going to be some sort of a tissue injury. So when we talk about some sort of tissue injury, this could be tissue such as vessels, blood vessels. This could be actual tissue like skin. This could be muscles that are getting torn down. It can be localized to a certain area, or it could be systemic all throughout the body. Good example of this could be like spider bites, snake bites. Their job is to tear down tissue and tear them apart, not through like literally tear them apart, but through the chemicals that they release. That's when we start to see a type 3 response. It's still going to be pretty quick, but again, it's either going to be localized or more systemic. You get some severely poisonous spiders or severely poisonous snakes, and that gets into the bloodstream as our concern, as opposed to maybe one that's not and bites you. You're still going to get a local response. You're still going to get that inflammation. Type 4 is going to be the most delayed. This is when it's going to take days before you really see a response to something. And this is really when we're talking organ transplant. Initially, the body might not fight it off, might take a little bit of time. It's going to take a whole lot of energy for a body to fight off an organ. So it's going to take a little bit more of a time frame before you start to see a response in the body. One of the things that I wouldn't say is most fearful for us, but things we're going to see very commonly are people with immune system disorders. And it could be something as simple as rheumatoid arthritis. It could be diabetes. I want you to remember Graves' disease. What it is it's issued with the thyroid. The thyroid is essentially in hyperdrive at this point. What happens is your thyroid controls your heart rate, controls blood pressure, controls respiratory, controls a whole lot of stuff. So in patients that have Graves' disease, we will see a heart rate that's severely elevated. We will see blood pressure that's really elevated, and we can see patients with an extreme temperature. You can also, this is sometimes classified, if you've ever heard the word thyroid storm or thyrotoxic storm. That's very much an example of Graves' disease as well. And again, any sort of immune system issue is generally relating back to our thyroid. Can people have an overactive thyroid? Yeah, they can. They have a really fast metabolism. These are people that are generally really skinny, as opposed to an underactive thyroid. People that are a little bit more overweight, their body can't fight off infections. They can't fight off any sort of sicknesses as well. Other examples, myasthenia gravis is a nerve issue. What happens is the body essentially turns on these nerve tissues. And the problem is these nerve tissues line our spine, or our spinal column, our spinal cord. So what happens in myasthenia gravis is you get the breakdown of this, and you can actually see patients paralyzed over time that lose normal bodily functions just because their immune system has turned on those nerve cells. Lupus, if you know anybody with lupus, if you know anybody with Raynaud's, very much immune system disorders as well. What happens is that those people generally get reduced blood supply, especially to their extremities. That's why people with lupus or people with Raynaud's are always saying their hands are cold or their extremities are really cold. It's due to that reduced blood supply to that area. Neutropenia is just going to be a decrease in circulating white blood cells. It's the body's lack. They don't have enough white blood cells to fight an infection. So this could be somebody that maybe developed this due to chemotherapy, that their body just, again, can't fight infections. If you ever heard somebody say they have, a really bad immune system, they might think that, maybe they don't truly have any diagnosis, but they also could have something. That's really important for us to assess as paramedics, especially with our patients that are very sickly or elderly, is if they have an immune system disorder, because their body might not be able to fight off whatever it is. It might be a common cold, it might be a common sickness, it might be a common illness. Their body just can't fight it off. They don't have that ability. HIV actually is another big one that I was trying to think that takes a toll on our immune system, allows our body not to fight things. My mother also has a severe immune system disorder. She cannot fight off infections. She cannot fight off illnesses. She cannot fight off even the common flu. We'll take her out for weeks just because her body doesn't have these B cells, these T cells to attack infections. Generally, immune system disorders are inherited. There is somewhere down the line in our family, somebody had immune system problems and we inherited them. A lot of people, I put this in this slide, are asymptomatic, but have chronic sinus issues. Why would they have chronic sinus issues? Well, it's because that's, again, one of the first lines of defense for anything entering the body. Well, when the body can't tell what's foreign and what's not, or the body is constantly trying to fight, it's producing a lot of mucus. We get the constriction of the sinus canals. Hence, these people have long-term sinus issues. Now, can people develop immune problems over time? Yeah, absolutely. Lack of eating good foods, stress, daily stress, long-term stress that we just haven't dealt with, lack of blood supply, hyperfusion or shock for a period of time, organs that assist us in fighting off infection. Think of patients that maybe don't have reduced supply of bone marrow. Bone marrow is literally responsible for producing red blood cells, white blood cells. So without bone marrow, they can't fight off infection either. So immune problem could be secondary to something else as well. How do we fix these? We don't. These patients are going to be in the hospital for a period of time. This is when they're getting blood transfusions. They're getting bone marrow transfusions or bone marrow replacement. Again, so their body can naturally try to fight these off. A lot of the things that we are going to see as far as diseases, or even if you know somebody that has a disease, it's either genetic. So it was present at birth, passed from parents' genes, somebody in the family's genes to future generations. Environmental, such as our own lifestyle habits, our exposure to chemicals in the environment, where we live, or the climate of the environment is going to take a toll on certain disease processes. Anatomic issues. So what anatomic issues could affect disease? Well, or diseases affect anatomics. Disease of the spine. That's going to cause irregular curvature. That's patients that could essentially be kind of like hunched over. Diseases of the heart might not be able to pump effectively. Diseases of the muscles, muscular dystrophy. Those patients might have muscles that are malformed or their body's just not in normal shape. Or we have immunologic responses or factors, such as that one I brought up, myasthenia gravis, where the myelin sheath of the spinal column is just slowly torn apart. Those nerves are slowly destroyed, leading to potential nerve damage over time, potential paralysis, potential lack of common functions that we would think, grabbing things, walking. I mean, over time, we can see that. Things that we can control your diet. You control if you use tobacco. You can control what you eat. You can control how active you are. We might not be able to control all of our stress, but we can maybe find something that helps us with stress. Things we can't control is who we are. We can't control our race. We can't control our sex. We can't control what genetics our parents handed down to us. These are modifiable versus non-modifiable. Modifiable are things you can change in your life. Non-modifiable are what the cards you were dealt, essentially. Again, remember your extremes of age. Newborns and older populations. Those are the ones I'm most worried about when it comes to diseases. They don't have the immune system to fight off whatever it is. Infants they just haven't been around it. They haven't been exposed. If any of you have kids, the first time you send them to daycare or they were daycare for a little bit of time, started hanging out with friends, they got sick when they came home, right? Their just body wasn't used to it. As opposed to us in our, middle years, I'll say, our body is kind of at its prime. It's at its peak. It's seen some stuff. It's still got to see a whole lot more, but it's seen its fair share of illnesses. So it knows how to fight certain things off. Now, there's also the conditions that are going to be more prevalent to us as men versus women, such as testicular cancer, right? That's just for a certain sex. Females, you're more prevalent for like breast cancer. Can males develop breast cancer? Absolutely. Prostate cancer for males. Also, when it comes to diseases, I hate to say this, guys, we're wussies. Women can hide diseases a lot worse than we can, or a lot better than we can. Even when it comes to common sicknesses and illnesses and pain, statistically, women hide pain better than men. It's statistics, call it what it is. So we're going to present differently. Older populations are going to present differently as well. What medications is somebody on? Is somebody on a pain medication? Maybe they're not going to present with pain then because they're taking pain medication for something else. When it comes to analyzing a disease or a risk of a disease, let's think, oh, I don't care, bird flu, for all I care, avian flu. There's some things we look at. We look at the incidence, number of new cases in a population. What they're trying to determine is this isolated to a certain area, or is this isolated to a certain demographic? They do that through incidence. Prevalence, number of cases in a period. From January 1st to December 31st, there were this many cases. That's how many cases were prevalent in that time frame. Morbidity, is there a presence of disease in a certain population or in a certain area? And then mortality, what injuries or what death are we seeing due to this disease? So these are things that all have to be looked at to determine if what risk is available or what risk is there for us as the public when it comes to diseases. So what always gets said is recommendations: wash your hands. When COVID, it was wear a mask, don't go outside, all this stuff. Every disease process is going to have things that we can do to not prevent it, but to potentially help us in dealing with it. Nothing is 100% preventable. Some common diseases, things that we can change. Emphysema. Most of the time, long-term smokers are going to develop emphysema or some form of COPD after a period of time. I'm just looking at a couple of these. Sinusitis. So inflammation of the sinuses. Those patients are going to get large amounts of mucus production. Could be caused by poor immune system. You can't change that. Could be caused by poor general health. You can only fix some things in that. You can fix your nutrition. You can fix your exercise. You can't fix your immune system, unfortunately. Asthma. I was a kid that had really bad asthma, and over time I kind of outgrew it. But as a kid, I had to be really careful on what I did physically, just because I could have an asthma attack. I also had to be really careful about what I was around, dogs, cats, because I could get a flare of my asthma as well. So those are just certain things that we can change when it comes to certain disease processes to make sure that we're not flaring anything up or causing that disease to kind of worsen. There's 20 slides left. I promise I'll quit talking then. Genetic risks, family tendencies when it comes to diseases. What diseases are potentially handed down? We should probably know, and that's important when we're assessing our patients, is do they know what diseases are running their family? Somebody with chest pain, I want to know, do you have any family history of chest pain? Do you have any family history of this? Do you have any family history of that? Is it prevalent to the situation? Maybe not, but it's something to write down, because maybe the doctor at the hospital knows that they then have a tendency for what you're seeing, for the signs, symptoms that you're seeing. So asking certain questions like that is not wrong, and it's something we should absolutely be doing. Okay, cancer, one of the most common things we're going to see. So associated with malignant growths, can be all over the body. Can have liver cancer, lung cancer, kidney, all types of different cancer. Number one thing that we can change is lifestyle when it comes to cancer. We can't prevent it from happening, but we can prevent some of the risks, such as cigarette smoking for lung cancer. Those of us that work in the fire service, those of you that work at a fire department full-time, you're more at a risk. I wouldn't say full-time. If you work at a fire department, you're more at a risk of developing lung cancer or prostate cancer just based off of your job. These are just predisposing factors to that job. Breast cancer, most common obviously in women. Can men develop it? Absolutely. Colorectal cancer, third most common type of cancer. Prostate cancer is making a comeback as well, especially for our male populations, and that's what we're seeing a lot of in first responders. Type 1 versus type 2 diabetes. Type 1, also called juvenile diabetes, is going to be insulin dependent. Type 2 is your non-insulin dependent. Now, type 2 can usually a lot of times be brought under control with like weight loss, changing lifestyle, as to where type 1 can't. Those patients have that for life. Those are the patients that have to manage their diabetes through insulin injections or through some sort of like an insulin pump. A friend of mine is diabetic, managed it through a pump. I didn't know for the longest time until he told me. He managed it on his phone. Actually, he had a wireless pump and was able to manage them. Again, I would have never known unless he had told me. So it's not that these patients have any sort of different lifestyle, or these people have any sort of different lifestyle. They just have to manage their life a little bit differently, and they got to maybe watch what things they're eating or how much medication they're taking. Some of the blood disorders I talked about. So we have anemia, we have hemophilia, we have hemochromatosis, which is excess iron in the blood. Anemia is going to be, very much like increased destruction of red blood cells. Naturally, over time, red blood cells are going to break themselves down. But when somebody's anemic, is that their body destructs red blood cells faster than it should. Hemophilia, very much an inherited disorder. These patients tend to bleed a lot. It's literally categorized by excessive bleeding. One of the first patients I ever started an IV on was a hemophiliac. I didn't know it at the time. I started an IV. There was blood everywhere. He thought it was hilarious. I was terrified until he told me he was a hemophiliac. I didn't know what that was at the time. I was a brand new paramedic student. Afterwards, I went out in my car. I Googled what the hell hemophilia was. And that's when I found out that it causes excess bleeding. But these are just some of the common things, especially we can see handed down through generations, is anemia, hemophilia, or the ability to carry excess iron in the blood or have excess iron in the blood. Cardiovascular disorders are absolutely handed down through generations, absolutely handed down. Now, there's going to be certain things, again, when we get to cardiology, that should dictate if you put somebody on a 4-lead, put somebody on 12-lead. Syncope is a huge reason to put somebody on 12-lead. If somebody had a fainting episode or felt like they were going to faint, you should absolutely be looking at what's going on with their heart. If they have a history of it happening, could it be a sign that maybe their heart is slowing down for some reason? Absolutely. These are reasons we should absolutely be looking into their cardiac family history. Hey, does your family have any history of cardiac problems? Cardiomyopathy, any diseases of the myocardium, myo meaning middle, cardium muscle of the cardiac system. So if you look at that diagram of the heart there, you can see the muscle in between the myocardium is thickened in that bottom picture as opposed to that top one. What happens over time is that muscle becomes hypertrophic. So that muscle gets bigger. That muscle has to take up some space, so the atrium or the ventricles that are a little space there become smaller because that muscle has become bigger, which is great. You think, okay, muscle being bigger, that means that the heart's going to be more efficient. That's not the case. Even though the heart can have more strength, that doesn't mean it's pushing more blood. Because again, look at that on the right side of your screen at the bottom, that compartment versus up top. You can see the difference in size. So I'm essentially pushing less blood because I don't have that much blood filled up in that area. If somebody has an enlarged heart muscle, you can actually see that on an EKG tracing. When we get to EKGs, I'll show you guys how to do that. You'll very much see almost like a blip or a complex that is way bigger than it needs to be. And it's because it's taking a lot more energy to cause that muscle to contract. Other common ones, mitral valve prolapse. So valve inside the heart that's generally only supposed to go one way. Well, when that valve essentially turns inside out, that's when we can get a prolapse of valve. Coronary heart disease is the most common thing that we will see in regards to family disorders or family handed down diseases. Somebody that has coronary artery disease or coronary heart disease probably got it from somebody in their family. Generally categorized by like a massive amount of plaque that is built up in the bloodstream. That's our concern for somebody having an MI, is that plaque is going to turn into a clot. Hypertension can be handed down. We're worried about strokes when it comes to hypertension. Because again, blood vessel walls can only withstand pressure for so long. And eventually our concern is that one of those vessels is going to burst. Gout can be handed down. Generally categorized by, pain in the joints, swelling in the joints. They used to call it like the rich man's disease because eating excess amounts of protein can also cause this, like red meats. Kidney stones. If you've never had a kidney stone, kudos to you. It's just a buildup of uric acid within the kidneys that body can't break it down. And either we go into the doctor and they're able to use like a laser and break it apart, or we have to pass it naturally. Passing it naturally, if you have a patient with kidney pain or a kidney stone, the best thing we can do for them is treat them with pain management. It is the most painful, one of the most painful things you'll ever deal with. Sometimes, again, we're not fixing everything about our patients, we're managing signs and symptoms. If our patient's in pain, treat their pain. We don't know what they're feeling at the time. Lactose intolerance is also very much handed down. Body's inability to digest lactose or milk sugar. Ulcerative colitis, which is generally very much an ulcer along the digestive tract. That's where you're gonna see patients with like abdominal pain, profuse diarrhea. Maybe they have blood or a mucus discharge. Something that these patients should know or should be told to them, especially if they've been diagnosed with ulcerative colitis or even Crohn's disease, is there's certain things that they can't eat because certain things will flare it up and make it worse. A good friend of mine also had problems with Crohn's disease. There were certain things he couldn't eat. He couldn't eat red sauces. He couldn't eat like heavy creams because his digestive tract, his body just couldn't digest it. Peptic ulcers, so excess acid production. What happens is it starts to break down membranes within outside of our digestive tract. Gallstones, obesity. That's one of the most common things. And again, I'm a big dude. But the problem is being a bigger person, your body can't fight off infection as well because you just don't have the energy. Being a bigger person, your body exhausts a lot of energy for normal bodily functions. So when it comes to being sick, you actually have a decreased immune system. Your thyroid isn't as active, so you don't have the immune system of somebody that's maybe in a little bit better shape, unfortunately. I talked about some of these muscular dystrophies, so the breaking of the myelin sheath along the spinal column. Multiple sclerosis, again, is breaking down of that sheath. Alzheimer's, horrible disease, especially for our elderly population, where their brain essentially deteriorates over time. It almost shrinks down. Some psychiatric disorders that can be handed down: schizophrenia, patients that are bipolar potentially. Not everybody is faking a psychiatric disorder. Some are real, and talking with these patients might be some of the best treatment that we can give them. You know, we don't have to just assume everybody's crazy. Sometimes the best treatment we can do is have a conversation. Stress, I'm not going to hit a whole lot on stress, but it's bad for our bodies. Our body responds to stress differently. You know, it'll dump a whole lot of adrenaline. We become really worked up. Our blood pressure's raised, our heart rate's up. Well, our body can only handle stress for so long. Whatever is causing the stress is the stressor. The effect of the stress on our body is high blood pressure and increased heart rate. And then what's our response to that? How does our body respond to stress? You know, we have fight or flight, or we have rest and digest, where we want to, you know, just kind of, well, hopefully it'll work itself out. Or we have the people that have to confront stress head on. So there's different responses by each type of person. Now, stress, again, can lead to chemical dependency. It can lead to heart attacks if left untreated. It can lead to depression, anxiety, headaches, abdominal pain. And we have the worst profession for dealing with stress. So the first step of the general adaptation syndrome is what causes the stress? What's alarming the body to release? You know, initially in stress, we release epi, we dump epinephrine, we get that adrenaline rush. What's causing that? That's the alarm phase. Our respiratory rate increases, our blood vessels change, our muscles, our pupils dilate because they're trying to figure out what's going on. We have the resistance phase, where our body is going to start to secrete different types of steroids to deal with blood pressure. And it's trying to, again, return us back to a homeostatic state. And then we have, still the resistance phase. We have the exhaustion phase. Our body can only deal with this for so long. We are very much a machine. There's a point where our body will just shut itself down. Once we're exhausted, once we've used up all our energy, once we've used up all of our adrenaline, our body's got to reset. And we will literally collapse until our body has the nutrients and the energy it needs to continue on. Most everything with stress is going to be controlled through our pituitary gland. That's going to control our reactions to stress because, again, that's producing epinephrine. That's producing adrenaline. Without that, we have no response to stress. We don't get worked up. We don't have an increased heart rate. We don't have an increased blood pressure. When we are stressed, our body slows everything else down. Stress is not just stress on the brain, stress on every single organ we have. So what happens is that organ slows down at its ability to do normal functions. How do we cope with that? Change our lifestyle. It could be something such as therapy. It could be a medication. It could be, finding some habit that's not addictive, and using that to kind of reduce your amount of stress, or just trying to remove the stressful stressors in your life altogether. All right, that's the end of the slideshow. I'm going to give you guys 10 minutes, and then we're going to come back. I'll show you guys platinum. So take a 10-minute break, and then I'll answer any questions you guys have at that point. I didn't pay attention to what time we stopped. So I'm gonna give us like 2 minutes. Does that seem right? Or somebody tell me if I'm wrong?
I'm ready.
All right, we'll give the others 2 minutes.
Oh, Rudy, just a question. I signed up for like a ton of clinicals in Des Moines. But the ER ones are all pending.
That's because I have to approve those. I have to make sure that there's no other students in the ER that day.
Okay, so is it like closer to the time they come through then?
Do what?
It comes through like closer to the time?
No, I just haven't logged into Platinum besides right now today.
Okay.
So that's
Okay.
it'll get approved when I usually it's approved well ahead of time.
Okay, sounds good. And then the other one is you guys were saying that we needed to do a pediatric floor in Des Moines. I don't see that on there.
That's because the floor. I'll
Y'all
send
explain
you a message privately about that.
it? Okay, thank you.
Mhm. All right. So you guys should know how to create a lab, which you guys have been doing. The thing there's some confusion on is lab versus scenarios. So when we start getting into just scenarios, which we have to do a lot of them, which is just assessing and working through, I tell you there's an 85-year-old female with abdominal pain. And just you working through the whole scenario. It's not so much performing skills. You're doing the skills in your clinical and field settings. This is more critical thinking. So when it comes to how to document that, well, you have to create an opportunity. Now you're used to opportunities as far as clinical and field goes, but this is just scenarios and simulations. And the only opportunity you can create is simulations. So you're going to go to, so let me log in as a student, my bad. You're going to go to opportunities and then click my opportunities. It should pull up any that are assigned to you. So if you have a clinical signed up or a ride time or anything like that, you will see that here. Now, if you need to create a new scenario or simulation or where to document it at, all you're going to do is hit this create opportunity up at the right. It will bring you to the screen where it says student generated opportunity for the title. It defaults to clinical simulation, defaults to simulation center and lab. All you do is let's just say Clinton. So I'm going to pick Clinton Fire Department because that's where we did the scenarios at. What time we did them at 7 p.m. We stopped at 2100. And then who went through them with us? This should be one of the instructors. Even though all the preceptors are going to be named here, it's just who went through them with you as far as instructor goes. Once you hit submit, it's going to pull up essentially like documenting in a clinical and field shift. You have your overview, which tells you the site, tells you the time, tells you where it happened. You have your information, such as your preceptor. You can put notes in here, like, I don't know, if you want to put accidentally stuck myself with IV catheter. That's a note that'd probably be worth noting because that's something that's going to red flag to me. Now, I'm going to save. See on the left-hand side, it says patients. I'm going to go there. Now, let's just pick an 85-year-old female abdominal pain. So contact chief complaint, abdominal pain, gender, female, years, 85. Let's see what the scenario we had an 85-year-old adult female complaint of abdominal pain for 3 days. History of So I'm going to put in here what we did. Patient administered 50 micrograms of fentanyl and monitored. Okay, something small, something sweet to the point. Patient encounter is going to be formative. The age group automatically defaults. Since it's a simulation, some of this stuff doesn't count. Some does, because you're allowed to simulate so many items. So if you don't document it, then you don't know if it's going to count or not. Exposure is formative. Pathology, it's not one of these, so I'm going to leave it blank. What skills? Okay, well, we did a fentanyl, so we did a bolus medication. It was successful. We did IV access, and that was successful. That's all you have to do for your scenario. Now, if you do more than one scenario, then all you do is add another patient. If maybe there's like a 4 lead or a 12 lead you want to attach to it that was printed off on a monitor or something like that, you can do that under documents. The only thing you'll have to do from here is submit it. And when you submit it, it sends it straight to me as the instructor to basically allow it to show up on your progress. Now, the only difference between that and a clinical and field is that I create all the clinical and field for you guys. This is the only one that you will have to create when it comes to scenarios. Lab is just skills. Scenarios is working through the assessment on a patient where you're maybe not doing the skills, you're just doing a scenario. Are there any other questions of Platinum that Cheryl didn't tell me about, or I just want to make sure I clear everything up for you guys?
I got a question on the PCR and field report side.
Okay.
So when I go to the opportunity, I go to documents.
Uh-huh.
I'm trying to remember which one exactly it was today. The one comes up and it does not code out in computer language. So it just comes up as a bunch of gibberish when I try to download it.
You don't,
So
is that under forms? Is that what you're saying?
Yeah, that's under forms. Like
Yeah,
the EMS generic run report form comes up fine.
Okay. And you don't have to fill that out. That's just, it's literally a blank form to tell you like how to work through an assessment. It's just a form for you to be able to write down on.
Okay.
All you have to do
my
for a
next
field
question.
patient is document them just like you would a scenario. Short, sweet, to the point. What you did for the patient,
Okay.
what was done during transport, any patient responses, and that's it.
Okay. So I'm fine then, because I did a run report for each patient's day plus my normal Platinum documentation.
Yeah, then yeah, you're fine. That form is just there as a guide, like for what things that people would want to ask or something like that on a field call. That's not mandatory. I just put it on there as a form.
Okay, so we run a mega code today, and I pushed a lot of medications. So is the time the medication was pushed really pertinent then on that run report, or can I just submit it that way?
No, you can submit it that way. What I'll tell you
Okay.
is like, so if let's just go into this patient, it doesn't ask what medication I give, right? So let's just say administer IV medication. It doesn't ask what medication. So in my narrative, I should put 50 micrograms of fentanyl administered. That way the medication is documented. This is the skill of pushing the medication, but here's how much I gave and the medication name. Put that in your narrative.
Okay. Got it.
I will very much still be working during your guys' break. I'll still be responding to messages. I'll still be responding to emails. If I do not respond after hours, after normal working hours, unless it's an emergency, I'll get to it the next day. Please still send me questions, send me anything like that. If there's anything I need to call you about, then I'll call you. Your final is open till Friday. You have till Friday to complete it. It's open book, like I said, 100 questions. It's nothing crazy. Everything in that study guide is literally, I literally read through every single question and put the stuff on that study guide when I made it. First semester sucks because it's a lot of cells, a lot of information that honestly you're going to forget by the end of next semester. Next semester is kind of a big one. Learning diseases, learning the signs and symptoms of the diseases, where we really start to get our aha moment as a paramedic, where you start to say, okay, if you see this, this is what's probably going on. You see this, this is what's probably what's going on with my patient. That's really when our assessment comes into play. That's really where we start to kind of feel like a paramedic. First semester is like, what the hell did I just learn? So first semester is like, why is this all being thrown at me? This is stupid. I'm not going to remember any of this. Don't freak out. That's normal. When we start getting into disease processes, I'm not saying the cells or anything are going to make more sense, but some of the medications and some of the things that we talk about with disease processes, it will make sense. And it's even with patients that you've seen now as an EMT. So don't freak out. Again, if you guys have questions during break, get a hold of me. I'll answer to the best of my ability. And if I can't, I'll call you and try to work through something with you. If for some reason you have trouble with platinum, absolutely shoot me a message. And I'll try to answer whatever I can for you. Any
Rudy, has Chief Chapman contacted you at all?
Do what?
Has Chief Chapman contacted you at all?
About scheduling?
Yeah,
I think he sent me a text, and I told him if you're looking to schedule with Clinton, all you have to do is send an email to me with him CC'd on it with the date and the time, and I'll get it created.
Oh, okay.
Yep.
All right, thank you.
Yep. Any other questions? And Jackie, just looking, I don't think PEDS floor is open till third semester. That's why, because you have to go through PEDS first.
Okay, sounds good. It was written on this first semester in your guys's
Yeah, I think I changed it to not say that anymore though, because it doesn't make much sense to go through that with you guys.
okay. So then one more question here. So okay, so to get my 96 hours, we can just do like extra days in the ER then?
What do you mean?
Well, like I went through and I've taken hours for everything that's on that list, but I still don't have 96 hours.
Yeah.
So do we kind of
Yeah.
do it at our own discretion and the ER is the smartest?
Yeah, exactly. Yeah, you just pick the units. Most of the time, yeah, people are gonna pick the ER. So
Okay.
that's where they feel more comfortable.
Okay, sounds good. Thanks.
So I got a question.